Kira Koto, my name is Jesse. I'm an anesthetic technician in New Zealand. Today, the topic is called bronchospasms. So the previous topic, I have been talking about laryngospasm. Now today's bronchospasm. So if you come up with a situation like that, what are you going to do first? And then further investigation in the treatment for the bronchospasm. So like I said, I work in New Zealand, and in this video, I use the materials from my hospital. So hopefully one day when you come to New Zealand, you get familiar with the protocol. And I think each hospital, they have different protocol, but all the materials in New Zealand, they could come up quite the same. And hopefully you will get familiar with it. And it's also a good learning resource for you when you prefer how to deal with the bronchospasm, and you got a guideline. So hopefully you will subscribe my channel and share my channel to your friends. So you never know, one day you will come to New Zealand and work. All right. So now I will mention how to deal with the bronchospasm. Okay. Yes, if you come up with the patient will have the bronchospasm, firstly, main priorities maintain SpO2 above 95% with peak airway pressure below 50 centimeter of water. Inform surgeons, minimize surgical stimulation. You have to say to surgeon, can you stop, please? I have the airway issues. Check airway positions, ET-CO2 trace, and airway pressures. Manually ventilate to confirm high pressures and ensures adequate VT. Deepen anesthesia. If using desflurane, you can switch to alternative, like you can use propofol or sevoflurane. Emergency drug therapy like inhaled salbutamol, like 12 puffs if the patient above 6 years old, and the patient below 6 years old, you have to give 6 puffs. Inhaled ipratropium bromide, like 6 puffs via the circuits. Okay. And then IV salbutamol, like 250 microgram slow bolus, and repeat at 10 minutes if no improvement. IV adrenaline, 0.1 to 0.5 mils of 1 in 10,000 adrenaline. And optimize ventilator settings, long expiratory phase, low beep, and small tidal volumes, and intermittent disconnections. Order bolus drugs adjuncts listed in the priorities orders, like hydrocortisones, magnesium, ketamines, or aminophylline. If no improvements, consider adrenaline or aminophylline infusions. Place arterial light and take series of ABG, arterial blood gas. So we have to check. So normally, like I say, first thing you have to stop the surgeon. Like we said, the patient have an issue. So could you stop, and then you have to make sure that give the oxygen 100%, and to check the airway position, check the HT, CO2 trace, and airway pressures. So normally in New Zealand, we check if patient something like that, we just give the salbutamol with the 12 puffs if the patient above 12 years old, and then if the patient below 6 years old, no, if the patient above 6 years old, we give 12 puff, and then below 6 years old, we give 6 puff. And then we have different anesthesia. We give some muscle relaxant to relax the patient. That's what we use. Like I did on all the main medication like hydrocortisone, and then magnesium. Magnesium is also good to relax the bronchos, so to stop the bronchospasm. That is the first thing you have to do when you come up with the patient with the bronchospasm. And now we will mention about the further cases and what we are gonna do. Okay. Always consider other causes of high airway pressures other than primary bronchospasms. You can most common include like anaphylaxis, laryngospasm on alarmized, tip position, chest wall rigidity, pneumothorax, and Alveolus failure. Permissive hypercapnia may be required in order to decrease airway pressures. Assess a response by decreased airway pressures, ABGs, arterial blood gas, and improving ATs, CO2 trace. That's what we should do to help to prevent the bronchospasms. Now we go continue for treatment. If the patient got the bronchospasm, what we are doing next. So the first thing we have to do now is further investigation. Now is we go to the treatment of the bronchospasm. Hopefully you can remember. This is all the medication we normally give to the patients if they have the bronchospasms after we try to solve the problem. Like salbutamol IV, you can give IV, you can give the inhalations. So IV slow bolus like pediatric below 2 years old, the dose like 5 microgram per kg. From 2 years to 18 years old, 15 microgram per kg, the maximum is 250 microgram. Salbutamol infusion like 5 milligram in 50 ml of saline and then infused from 0 to 10 ml per hour. Pediatric 50 ml of salbutamol infusions 5 to 10 microgram per kg per minute for 1 hour. Then reduce to 1 to 2 microgram per kg per minute. Adrenaline infusions 5 milligram in 50 ml saline infused 0 to 20 ml per hour. Pediatric not recommended. Hydrocortisone 200 milligram IVs pediatric like 4 milligram per kg. Amiophylline low 400 milligram over 15 minutes. Infuse 50 milligram in 50 ml at 35 ml per hour. Pediatric low dose like 10 milligram per kg over 1 hour diluted to 1 milligram per ml. Maximum 500 milligrams infusion. Magnesium 10 millimole like 5 ml of 49.3% over 20 minutes. Pediatric 0.1 milligram per ml per kg of 49.3% over 20 minutes. Ketamine 35 to 70 milligram IVs pediatric dose 0.5 to 1 milligram per kg. That is the guidelines if the patient got the bronchospasms. Normally, like I said, I came up a lot of bronchospasms. The first thing we make sure that the patients not gonna have high pressures, and normally we give the salbutamol sprays like through the endotracheal tube. Like I said, in patient above 6 years old, we keep 12 puffs, and then patient below 6 years old, we give 6 puffs, and we deepen anesthesia to help people to help the lungs to relax, and normally we give common thing we give like magnesium. Magnesium is quite good for the airway, so it dilates the airways and help the patient breathe better. The hydrocortisones, I rarely see people use hydrocortisones or amiophylline rarely, and salbutamol infusions. No, in my career in New Zealand, I haven't come up with someone get the salbutamol infusion, and that's it. That is all what we gonna do if the patient get the bronchospasms. Thank you for watching my video, and hopefully you can subscribe my channel and share my channel to other friends, or like I said, it's a good learning resources for everybody to remind us, because like if I don't use it, I will forget, and then it's good to if you have time, you can watch the video or read the guideline again to gain the muscle memory, like what you want to do in these situations. If the anesthetist they're busy with the airway, what are you gonna do? You're gonna come and grab the salbutamol, the sprayers, or get some propofol, something like that, or any medication or muscle relaxant that can help the anesthetist. Okay, we are anesthetist technicians. That means we help the anesthetist whatever they need during the crisis situation. So thank you very much, and I'll see you in the next video. Okay, see you.